Okay, so we are paramedics and we've been called into a clinic where a patient has come in. He is 45 years old and experiencing fluttering feeling in his chest. So the on-site clinician has already placed the patient on the monitor. We've got a blood pressure cuff, we've got the SpO2 cable, basic set of vitals have been attained, and a 12 lead. At least the stickers have been placed on the patient. So you can see vital signs on the screens. Maybe not necessarily this one here, but the one in behind Blair. And we're going to start interacting with our patient. So some of the things that we would start off with would be introducing ourselves. Hi, my name is Anna. This is my partner Blair.
Nice to meet you, sir.
Both paramedics. What seems to be the problem today, sir?
So it sounds like you've been having this fluttering feeling in your chest for some period of time, and it sounds like no actual chest pain, just a funny feeling.
So we would then assess airway, breathing, circulation now that we know just a general idea of why he's come into the clinic. So the airway's open and clear. We would count respirations. So he's breathing around 16 breaths a minute, but because he has a funny feeling in the chest, I would ask my partner to please place either a nasal cannula or a non-rebreather on his face at this time. I'm going to delegate to my partner a couple of things. So Blair, let's make a 12 lead the priority.
Okay.
We've already got a basic set of vitals, and the vitals that are up there, the ones that I care about, blood pressure, heart rate, respirate, SpO2 are currently captured. He doesn't seem to be altered, so I can eliminate BGL from this and others. Not that they're not important, but for the moment they can just stay to the side. And let's get an 18 gauge IV in an AC, please. And I'm choosing AC specifically because if this is an SVT, then I want the IV to be closest to the heart as possible because the medication acts so quickly. I'm going to ask my patients some questions about the fluttering. And so again, this video is not necessarily about the assessment component, but you could ask questions about when did the fluttering start? Have you ever experienced this before? Are you having any pain in your chest? Is it moving down either of your arms or into your back, up in your jaw? We're just trying to distinguish between, is he having a STEMI? Are we having a rhythm disturbance? My suspicion is rhythm disturbance, but I do need to think about differentials.
And I think I feel okay putting the pads on at this point.
Yeah, sounds good. Thank you very much. So, do we have the picture of the 12 lead?
We do.
Okay,
yeah,
great.
12 leads here. It definitely looks like an SVT to me.
Yeah, okay, I agree. So we're looking at an SVT, okay?
So, sir, that means there's a kind of a circuit going on in your heart that's making the heart beat way too fast. And it's something we should change so that you're more comfortable.
Now, to make the best decision about the change, we need to find out if he's stable or unstable. So, sir, I have some questions for you. The fluttering in your chest, is it any pain there at all? Are you feeling short of breath? I would check to make sure that his ventilation was appropriate, and I'd listen to lung sounds at apices and bases, midclavicular, mid-axillary, to ensure that there's no pulmonary edema. Last thing I'll check is the blood pressure, 114/73, and Blair, we've determined him to be stable. So the vagal maneuver and the adenosine sounds like the plan.
Okay.
Any questions or any concerns with that plan?
No question at all.
Okay, great job. So, like Blair explained to you, your heart is beating too fast. It's one of the reasons you're having this weird sensation in your chest that is not making you feel too good. So the plan is for us to do a couple things to correct it. The first thing would be me asking you to kind of bear down and seeing if we can correct it without medication. The other way, if that doesn't work, we'll be pushing a medicine that will help kick your heart out of that rhythm. But we have something we can try first. Does that sound okay to you, or do you have any questions?
So how this works is I'm going to get you to blow into this syringe for 10 seconds. And when we reach the 10 seconds, we're going to take you on a little bit of a ride. We're going to lay you down, and my partner's going to lift your legs up. All right? Does that sound like something you can do?
Any questions?
Fantastic.
All right.
Okay.
I'm going to hold your legs, John.
I'm just going to take this off for a moment. Okay, and I'm going to count to 10 now. You put your lips around it.
Just print. All right, good.
All right, and blow, 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 blow. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
We're looking at the monitor, and we don't have it changed.
Okay.
At this point, you should have it changed.
All right, I'm going to put you back in that same position.
Good job, John. Did great.
I'm afraid that didn't work, so.
Blair, we haven't had any change.
Still on the SVT.
Still on the SVT. I'm going to take another blood pressure just to make sure that we haven't had any change in our blood pressure, because we want to make sure that he has remained stable as we progress through and do different interventions. Okay, so unfortunately that did not work, so we're going to have to progress to the medications. So what this medication will do is we'll put it into your IV. It'll make you feel a little bit terrible for a moment. And how it will act is it'll kind of pause what's happening in your heart and hopefully allow the better portion of your heart to take over. That's basically what's going on. You probably won't feel that great when this happens, okay? But it should only last about 10 seconds, and we're going to sit with you the entire time. Do you have any questions? Okay, so we're going to wait for Blair to, because Blair's been off to the side getting the adenosine ready. We're going to use 6 milligrams, and we're going to chase it with a 20 cc flush. We've already established an 18 gauge IV in either AC. Left is preferred. And we've got our ports here. So the adenosine will go into the port closest to the patient, and the 20 cc will go to the port, one port above. We've already got pads on the chest. We've already attained a 12 lead. We've got a new blood pressure, 114 on 71, so he still qualifies for this intervention. I'm just making sure he doesn't qualify for or change to a cardioversion.
So this is adenosine. It's 6 milligrams in 2 mils, and I also have a 20 cc flush ready to go.
Okay, great, sounds good. Okay, any questions before we start? All right, Blair, do you want to do the medication since you're standing there, and I'll do the 20 cc flush?
Certainly.
Okay, we're both paramedics. A PCP could not be the one pushing the medication, but a PCP could be the one that pushes the 20 cc flush.
I'm just going to swab the port here.
As will I.
Get it ready.
Okay, so before we push anything, let's just go over our plan, Blair.
Okay.
So you're going to connect, I'm going to connect. You're going to push as fast as you can and hold the plunger down. I'm going to then push as fast as I can. After the medication has been pushed, this is where you might feel a little bit terrible, and that'll again last for 10 seconds. So again, the plan is, Blair, you to connect there, me to connect here. Okay, you're going to push as fast as you can and hold the plunger down. I'm going to push as fast as I can. Hold the plunger down. Let's make sure all our connections are open.
All right.
No, that's not open. That would also prevent it. So we've got our IV open. Blair's knows the plan. I know the plan. And sir, we're about to get started. So let's be prepared for a feeling of uneasiness here. Ready? 1, 2, 3.
Good. Adenosine's in.
Good. And print. We just keep forgetting stuff. And so at this point, the patient might not feel great. He might start to, or she may start to go, oh! You were watching the monitor for the change. Watching the monitor for the change. No change has happened. At this point, it should have happened. So we can stop. Saying, so how are you feeling, sir?
I don't think he's feeling as well now.
So patient may not be feeling great, may still be feeling the same, but because he's not feeling great at this time, we're gonna make some things some priority. One, we are still in a heart rate of 199. So I need to ask you some very specific questions. Blair, can you grab me another blood pressure, please?
Absolutely, I'm
Okay.
cycling now.
How is the sensation in your chest? Has it become pain? And if he says yes, that's a problem. And I can OP-QRST that pain. I need to ask if you're short of breath at all.
He is short of breath and his rate's gone up and his PP has dropped to 79.
So I can actually stop what I'm doing because I already have criteria that says he has gone from stable SVT to unstable SVT. He has chest pain, shortness of breath, and his pressure is now 79 on 40. So sir, I'm gonna lay you down. Okay, I know you're a little bit short of breath. The non-rebreather is activated. I'm gonna call in backup and ask them to get resuscitation equipment ready, like an OPA and a BVM in case he goes unconscious. Next priority is I need to cardiovert him right now. The first cardioversion is done, unfortunately, without sedation because there's no time to waste. But Blair, when you have a minute, I need you to get 0.5 milligrams a kilo of ketamine.
Will do.
Prepared. So he's 80 kilos. Can you get 40 milligrams of ketamine as soon as you can?
Ketamine.
While Blair does that, I am going to initiate cardioversion. So I'm going to press sync. And I'm going to look for flags on top. Oh, I might have to change the view. There we go. So by changing the view, sorry, I can see now, and I'm waiting for my flags to be on top of the R wave. Once that has happened, I'm going to energy select down to 100 joules. And I'm going to explain to my patient, John, unfortunately, this is going to hurt. Your heart has changed and it's now in distress. So I need to give you some energy in your chest with the pads that I put on. I'm going to put you to sleep as soon as I can, but I'm going to warn you, this is probably going to hurt. Are you okay with that? He may or may not be, but we need to do this. So I'm going to explain it to him. I'm going to charge. I'm clear, you're clear, we're all clear, visual scan. Then I'm gonna press and hold. I'm looking for a change on the monitor. Now that the monitor has changed, I'm looking for a change in patient presentation. John, how are you feeling? Are you still awake?
Still the same, he's got a pulse.
He's got a pulse. My priority is a blood pressure right now. He's still in SVT, so I need to see, is he still unstable? John, are you awake? And if he's awake, that's good. I don't have to do airway management. I need to see if you're having chest pain still.
Still pain.
Still pain? Are you still short of breath?
He is, and I have ketamine now.
Okay, so he's still, despite not having a blood pressure rate at this moment, he's still unstable. But my blood pressure is coming. I can check his radial pulse while I'm getting ready to go. And I don't have a radial pulse currently.
Yeah.
So he's still unstable. So, couple things. Blair, is my ketamine prepared?
Ketamine's prepared.
Great job. We're doing this without delay, but we are doing our call management in a way that the ketamine's ready to go, so take a minute to push the ketamine. John, I'm gonna put you to sleep. The ketamine has just been pushed, and John has they're still awake when you have their eyes are still open when you have ketamine, but they are technically, especially at that stage, potentially asleep. So a little bit of airway management. I still have a patient who is unstable in SVT, pressure 77 on 37. It's all I need to continue cardioverting. Now my patient's asleep, so again, I have to press sync again. I am in lead 3 so that I can see the R waves with the flags so that we provide energy at the correct portion of depolarization of the heart, not during repolarization. I'm going to energy select up to 200 joules. I'm going to charge. We're all clear. It's been charged. I'm going to press and hold. And I'm going to look at the monitor for a change in rhythm. I can let go now. Okay, good. My partner has his hand on the pulse. I'm not going to do it at the same time because we don't want to affect coronary perfusion pressure. Because we've had a change in rhythm, and Blair, we have had a change in rhythm, I'm going to redo LOC ABCs. John, are you awake? John?
He is awake now.
He's awake. Good. Okay, so airway is being maintained. And to check his breathing rate, rhythm quality, make sure he still needs that non-rebreather. We're breathing around 20, so I'm still happy with that. Now I'm going to just double check pulse, carotid and radial, and now I do have a radial pulse, so that's a change in presentation. Priorities, again, is getting a full set of vitals and a new 12 leads. I need to see what rhythm he's in. So I can make that determination quite quickly by doing a print. John, it looks like your rhythm has corrected, so you might be a little bit sleepy from the medication that I gave you, okay? But we're going to go to the hospital here in a moment. Or we're going to get a doctor involved because we're in a hospital. So I printed a 6-second strip. I'm going to get a new blood pressure. Looking at all my other vital signs, heart rate's 79, SpO2's 96, EtCO2's 35, rest rate's 23. I'm happy with those numbers, and those are the ones that I care about currently. Taking a look at his rhythm here, looks like he went into a normal sinus rhythm, which is great. That's what we were trying to achieve. So we can put that off to the side and wait for our new blood pressure. Just ignore the 73. We're looking at a stat of 100%. So we have a new blood pressure of 136 on 99 with a heart rate of 80. I can cease going over Chad LS. There's no reason to do that anymore. He's not in a life-threatening rhythm, and I can provide continuous care from this point on.
You up at night, yeah. Make all the demons quiet, yeah. We were built to thrive, yeah. I think that we've all had enough. What keeps you up at night, yeah. Make all the demons quiet, yeah.